I was a line officer in the Air Force first, came in through ROTC, through Texas A&M, was a command post controller for 4 years, got a master's degree working night shifts, which allowed me to cross-train over into the Medical Service Corps. And so I'm a healthcare administrator. The Air Force has sent me to get 2 more master's degrees since then, one in healthcare administration and one in political science through PME. The majority of my career at the action officer level has been spent in finance and other business-related aspects of healthcare. But I'm privileged now to be able to run our medical group here, and so I have all of our healthcare operations underneath me. So we've got about 400 staff. We are a primary care operation, so we have 17,000 people enrolled to us for their primary care day-to-day, pediatrics, families, flyers. We also have an operational side to our business. So we take care of all operational aspects of military medicine. So for our primary care, we have family practice physicians, we have physician's assistants, extenders. We also utilize in the military nurse practitioners a lot, so I have family health nurse practitioners. And really have kind of all 3 in each clinic. And so like in pediatrics, I have a pediatrician, I also have a nurse practitioner, and then physician's assistants. So we count them all equally as long as I have enough physicians to provide appropriate oversight. In our flight medicine clinic, we obviously have physicians and physician assistants that have been sent to additional flight medicine training to understand what's required there. And also we have mental health, social workers, psychologists, psychiatrists, a wide range of specialties. So I've been in the Air Force for almost 23 years. I've been in military medicine for about 19 of those years. I think we've followed the trends that the Air Force and the military in general have followed. Our staff has gotten leaner. Our processes have gotten more automated, which sometimes makes things easier. Sometimes, though, there's a steep learning curve and it's not as easy as it would seem initially. We expect more. Our young airmen that come in today are expected to do a lot more, understand a lot more, have a lot wider reach than I think our young airmen were expected when they came in 20 years ago. Not recruitment at all. Recruitment's always good. People want to join the United States Air Force, and we don't struggle in recruiting. Sometimes in some of our healthcare specialties, which can be a little bit unique, we have trouble finding particular specialties. We have trouble sometimes in military medicine at the compensation levels of meeting compensation. You know, what we really are looking for is a provider who wants to serve, as well as is okay with the compensation. So that's kind of a good mix for us because, again, we know our compensation levels may not be on par with the outside. And so we do struggle in some of those recruiting areas in medical specialties, but all in all, everything's fine. We're a support organization for the bigger Air Force. And so as the numbers of the Air Force go, if we draw down in strength at the Air Force level, it just makes sense that the healthcare organization that supports that mission is also going to subsequently, ebb and flow. It can be extremely difficult, and one of the things that makes us unique, so from a staff perspective first, I have staff members that we deploy, and so when they're deployed, we try to take care of their families and such. I also have staff members that we call them dual military, so they're two active duty military families, and so they may be here seeing patients, they may have a spouse that's in Afghanistan, and they're a single parent at the same time, they're worried about their spouse, at the same time they're trying to do their mission. And so that can be challenging. We also take care of families, many families, whose significant other may be deployed. Sometimes we know that, sometimes we don't. The bottom line is we try to treat each patient with respect and kindness, give them the kind of trusted care that they would expect, and that'll be fine. So we talk about resiliency a lot. We talk about not just can I fix the healthcare issue that you have in front of you, but we talk about resiliency with our patients and try to get to the broader spectrum of do you have a good foundation, so we get through life's bumps. The good thing about us is those bumps in the road with deployments and everything else, it's culturally something we absorb, and so our culture understands that, and so we support each other and take care of each other. I think it's just awareness. I think, again, I'm not a physician, but my experience is, PTSD has to have always been around. Talk about our World War II veterans and the things that they went through. It's just we're more self-aware now. We can treat it better now. We understand now what our redeployers go through and the stress that puts on their family and their reintegration, and so we can much more proactively engage with those folks and try to help them have a good outcome and not really leave them to figure it out themselves, which I think is what kind of used to happen.